Welcome to another episode from the Veterinary Medicine Digest. Hello everyone, and welcome to the podcast dedicated to exploring the complex, often enigmatic, world of feline health. Today, we delve into a puzzling condition known by many names, reflecting the medical mystery it presents: feline hyperesthesia syndrome. This disorder is also recognized as rolling skin disease, twitchy cat disease, apparent neuritis, or atypical neurodermatitis, names which immediately hint at the confusion surrounding its true origin and nature. Feline hyperesthesia syndrome, or FHS, is considered a poorly understood maladaptive pain condition, and typically, it is a diagnosis reached only after excluding all other possibilities. The characteristic signs of feline hyperesthesia syndrome were first reported as early as 1980. This complex entity is thought to involve interactions between dermatological, neurological, and behavioral fields, complicating the diagnostic process immensely. The clinical portrait: unraveling the signs. The clinical presentation of feline hyperesthesia syndrome is quite dramatic and, unfortunately, often distressing for both the affected cat and its caregivers. The most recognized and often described sign of feline hyperesthesia syndrome is the rippling or rolling skin along the lumbar spine. This is actually the pathognomic sign of the condition, representing a reflex contraction of the cutaneous trunci muscle, which is intricately attached to the skin and fascia. This reflex contraction has earned the condition its nickname, the rolling skin syndrome. While this twitching response can occur following noxious irritation, it is also frequently observed during emotional states of high arousal. Beyond the rippling skin, episodes are characterized by a host of other striking behaviors. Cats may experience lumbar hyperesthesia, meaning they display heightened sensitivity or increased reaction to a normal level of stimulation, particularly around the spine and tail. Touching or petting the cat, especially along the back, may provoke or worsen the behavior. These episodes often include sudden and excessive vocalization. Cats may appear highly aroused, showing signs of anxiety, restlessness, or aggression, and they might have dilated pupils, a condition known as mydriasis. During a bout, the affected cat may seemingly attack or overgroom its tail, flank, or lumbar area, often leading to self-mutilation and soft tissue damage. In severe presentations, this self-trauma can be so intense that it results in tail mutilation, sometimes requiring surgical intervention. Cats may also engage in explosive bursts of activity, such as wild running, jumping, and pacing around the home, behaviors sometimes described as if the cat is experiencing hallucinations. In one study involving cats with self-trauma to the tail associated with feline hyperesthesia syndrome, frequent episodes of tail chasing and self-trauma were reported in the majority of cases. These episodes of unusual behavior or discomfort are typically episodic in nature. Regarding the cats most commonly affected, feline hyperesthesia syndrome is reportedly more common in certain breeds, including the Siamese, Burmese, Himalayan, Abyssinian, and Persian cats. Typically, the clinical signs begin to appear when the cat is relatively young, usually between 1 and 5 years of age. The etiological conundrum: 3 main hypotheses. The lack of a single, definitive cause is why feline hyperesthesia syndrome is correctly termed a syndrome. Its complex nature suggests involvement of the corticolimbic system, which is the brain circuitry integrating emotion with cognition to produce behavioral output. This system, comprising the prefrontal cortex, amygdala, and hippocampus, modulates pain and is implicated in maladaptive pain states. This overlap means that emotional disorders and chronic pain often have a high rate of co-occurrence, sharing similar neurobiological mechanisms. The 3 primary theories regarding feline hyperesthesia syndrome revolve around behavioral, neurological pain, and neurological seizure origins. Hypothesis 1: a behavioral displacement disorder. Many clinicians view feline hyperesthesia syndrome as primarily a behavioral disorder, specifically a compulsive behavior or a displacement behavior triggered by anxiety, conflict, or frustration. A displacement behavior occurs when an animal has conflicting motivations, for example, wanting to approach food but being too fearful of a nearby threat, or is frustrated because it is unable to complete a sequence of behaviors due to physical or psychological obstacles. In response to this internal conflict or high arousal, the cat performs an out-of-context, species-appropriate activity, such as grooming. If this highly stressed or frustrated state persists over a long period, the displacement behavior can morph into a compulsive behavior, manifesting even when the initial stressor or conflicting motivation is absent. The physical signs seen in feline hyperesthesia syndrome lend credence to this theory. For instance, the rapid switching between behaviors and the thrashing of the tail are common responses in frustrated cats. The brief, intense grooming behavior often directed at the shoulder or base of the tail is itself a classic example of displacement activity in a frustrated cat. High emotional arousal, whether anxiety, fear, or frustration, can explain many of the signs observed, including mydriasis and hypervigilance. The expression of feline hyperesthesia syndrome is significantly influenced by the cat's emotional state, similar to conditions like feline idiopathic cystitis. Hypothesis 2, a neuropathic pain or itch disorder. A strong, competing theory is that feline hyperesthesia syndrome represents a form of neuropathic pain or neuropathic itch. Neuropathic pain arises from abnormal processing of sensory signals within the central or peripheral nervous system due to damage or dysfunction. The physical manifestations of feline hyperesthesia syndrome, specifically the extreme sensitivity, closely align with definitions of abnormal sensory experiences. For example, lumbar hyperesthesia describes an increased sensitivity to stimulation. The rippling or rolling of the skin, either spontaneously or in response to light touch, fits the criteria for allodynia and/or allokinesis. Allodynia is characterized by pain resulting from a stimulus that is normally not painful, such as a light touch. Allokinesis is related, describing a sensation or scratching behavior evoked by a normally non-proprioceptive stimulus. If a cat is experiencing persistent abnormal sensations, such as tingling, burning, or electric shock sensations, these may provoke the intense self-mutilation observed in feline hyperesthesia syndrome. The pain experience, or perception, is highly complex because it is interpreted in the brain's pain matrix and is subjective, influenced by psychological factors like fear and anxiety. Neuropathic pain fundamentally involves neuroplastic changes in the nervous system, leading to amplified pain signals. A key concept here is central sensitization, which is the amplification of pain signals within the central nervous system, meaning the cat experiences disproportionate pain relative to the injury, contributing to allodynia and hyperalgesia. A crucial mechanism in the development of central sensitization and neuropathic pain is wind-up, an intensification of pain caused by a long-lasting increase in the excitability of spinal cord neurons following repetitive stimulation. This mechanism is mediated through the activation of the NMDA receptor. Thus, if feline hyperesthesia syndrome is driven by these mechanisms, treatments aimed at calming hypersensitive nerves become vital. Hypothesis 3, focal epileptic seizures. Although often disputed as spurious, the suggestion that feline hyperesthesia syndrome is a seizure disorder persists, particularly since some cats respond positively to anti-epileptic drugs that also possess anxiolytic or analgesic properties. In this theory, the characteristic episodes of feline hyperesthesia syndrome are considered manifestations of focal complex epileptic seizures. Cats experiencing focal seizures may exhibit unusual semiology, making diagnosis difficult. The abnormal sensations, licking, biting, may represent paresthesia or painful dysesthesia linked to parietal lobe epilepsy, while behaviors like head shaking, ear movements, and presumptive hallucinations are also signs that could be explained by brain neuronal network dysfunction. In recent case studies, electroencephalogram findings were used to support this possibility. In 2 cats presenting with signs consistent with feline hyperesthesia syndrome, electroencephalogram showed evidence of epileptic activity, including polyspike-like discharges or focal sharp waves originating in the temporoparietal and frontotemporal areas. This finding strongly suggests that in certain cases, feline hyperesthesia syndrome may be considered an intracranial disorder with idiopathic epilepsy as a possible underlying cause. A newly emerging association. Feline infectious peritonitis. In a very recent development in the understanding of feline hyperesthesia syndrome, there has been an unexpected link observed following treatment for feline infectious peritonitis. A long-term follow-up study of cats successfully treated for feline infectious peritonitis using the antiviral drug GS441524 noted that 2 cats developed mild neurological signs compatible with feline hyperesthesia syndrome, weeks or months after treatment completion. Since feline coronavirus RNA was not detectable in the blood and other laboratory parameters were normal, these signs were not considered a relapse of feline infectious peritonitis. This delayed neurological manifestation raises a hypothesis that these symptoms could either be a long-term adverse effect of the antiviral treatment, possibly a neuropathy, or they could represent a long feline infectious peritonitis syndrome, linked to long-term immunological effects triggered by the virus itself. This unexpected association underscores just how challenging and multifaceted the etiology of feline hyperesthesia syndrome remains. The diagnostic challenge. A system of exclusion. Because of the broad range of potential causes, the diagnostic process for feline hyperesthesia syndrome is a systematic and thorough exercise in exclusion. A comprehensive diagnosis requires a multidisciplinary approach, ideally involving specialists in neurology, dermatology, and behavior. The diagnostic workup begins with excluding all other possible medical conditions. This includes performing a full physical examination, neurological examination, and initial laboratory work such as a complete blood count, serum biochemistry profile, urinalysis, and testing for retroviral status like feline leukemia virus and feline immunodeficiency virus. If spinal pain is suspected due to restricted movement, diagnostic imaging like magnetic resonance imaging or electrophysiology studies may be considered to rule out intervertebral disc disease, neoplasia, or infectious myelitis. However, magnetic resonance imaging and cerebrospinal fluid analysis are often found to be unremarkable in true cases of feline hyperesthesia syndrome. In cases where a seizure etiology is suspected, specialized testing like electroencephalogram may be pursued, which proved useful in detecting epileptic activity in certain reported cases. Next, dermatological causes must be strictly ruled out, given the intense pruritus and self-trauma involved. This workup typically involves ruling out skin lesions through scrapes, cytology, fungal cultures, strict flea control, and carefully controlled elimination diets over several weeks to rule out food hypersensitivity. Certain food proteins, such as chicken and salmon, have been identified as potential triggers in some reported cases, underscoring the necessity of the elimination diet trial. In one case, a cat showed remission from feline hyperesthesia syndrome symptoms after being placed on a hypoallergenic elimination diet, demonstrating that an underlying food hypersensitivity can be a major component of the condition. Finally, if no primary neurological or dermatological cause can be identified, attention turns to the behavioral assessment, confirming the contextual information. Where the behavior occurs, who was present, and what happened immediately before and after the episode. The owner's reaction to the behavior is especially important, as attempts to interrupt episodes or offer comfort might inadvertently increase the cat's arousal or reinforce the behavior, particularly if it is an attention-seeking behavior. In the absence of a definitive lesion, a suspected diagnosis of neuropathic pain may be supported by a positive response to a trial using drugs known to be effective for neuropathic pain. However, this diagnosis by drug trial must be interpreted cautiously, as many of these drugs also affect emotional state, anxiolytics, meaning the positive response might stem from the reduction in anxiety rather than pain itself. The essential role of multimodal management. Regardless of the presumed underlying cause, be it behavioral, pain-related, or neurological, the consensus among experts is that feline hyperesthesia syndrome responds best to a multimodal treatment strategy. This approach integrates environmental management, behavioral modification, and pharmacologic support. Environmental and behavioral modification. For cats dealing with feline hyperesthesia syndrome, addressing environmental and emotional needs is paramount. It is considered an essential component of management, not an optional one. The approach often utilizes the 5 pillars framework, which focuses on optimizing the home environment to minimize stress and foster security. These 5 pillars ensure the cat has access to 1. A safe space, 2. Available resources, food, water, resting places, latrines, free from conflict, 3. Opportunities for play and appropriate predatory behaviors, 4. Positive social interaction, and 5. Olfactory enrichment. It is crucial to recognize that chronic stress or fear and anxiety can significantly potentiate pain signals via the limbic system. Hence, reducing emotional compromise is essential to mitigate the clinical impact of the neuropathic pain component. Behavior modification protocols involve counterconditioning and desensitization. Counterconditioning involves teaching the cat new behaviors that are incompatible with the problematic behaviors, often focusing on behaviors that encourage relaxation. Desensitization requires reinforcing these new, positive behaviors while gradually introducing stimuli or circumstances that previously provoked the feline hyperesthesia syndrome episodes. By successfully implementing behavioral modification alongside pharmacotherapy, recent studies suggest that this dual approach can be highly effective in controlling the effects of trigger factors, allowing for the eventual suspension of drug therapy after several months. In fact, in a recent retrospective study, cats managed with behavioral modification, even alongside pharmacological therapy, were more likely to discontinue medication after a year compared to those only treated pharmacologically. Pharmacological support, targeting the nervous system. Pharmacological intervention for feline hyperesthesia syndrome largely involves adjuvant analgesic drugs. Medications not primarily designed to relieve pain, but used to enhance the effect of primary analgesics or address specific neurological mechanisms, often targeting the central nervous system. Since feline hyperesthesia syndrome is characterized by disordered somatosensory nervous system processing, licensed analgesics alone are often insufficient. Gabapentinoids drugs like gabapentin and pregabalin are often considered first-line pharmacological options for feline hyperesthesia syndrome. Gabapentinoids function by preventing the release of the excitatory neurotransmitter glutamate through interaction with the alpha-2 delta subunit of voltage-gated calcium channels. Glutamate release is integral to nociceptor afference and pain signal transmission. By reducing this release, gabapentinoids are valuable for managing neuropathic pain and are also known for their anxiolytic properties. This dual action against both abnormal sensation and anxiety makes them particularly useful for feline hyperesthesia syndrome. Pregabalin is sometimes favored because it is reportedly 5 times as potent as gabapentin, and its elimination half-life may allow for twice-daily dosing, making administration more convenient for caregivers. N-methyl-D-aspartate receptor antagonists. Since central sensitization is mediated largely through the NMDA receptor activation leading to wind-up, blocking this receptor is critical for managing chronic neuropathic pain. Ketamine competitively antagonizes NMDA receptors and can be useful in the management of acute exacerbations of pain, often administered as a constant-rate intravenous infusion in hospitalized cases or as a subcutaneous injection to limit the development and advancement of neuropathic pain. Amantadine is an oral NMDA receptor antagonist sometimes utilized in long-term treatment. Antiepileptic and glutamate-modulating drugs. Topiramate is an antiepileptic drug often used in feline hyperesthesia syndrome, particularly in cases involving self-mutilation. Topiramate acts as a voltage-dependent sodium channel blocker, helping reduce the ectopic firing of peripheral nerves, and is also known to potentiate gamma-aminobutyric acid neurotransmission and inhibit glutamate neurotransmission. Phenobarbital is primarily used if a seizure etiology is strongly suspected, as it increases the activity of inhibitory gamma-aminobutyric acid circuits. Psychotropic medications, selective serotonin reuptake inhibitors, and tricyclic antidepressants. These classes of drugs address the potential compulsive and anxiety components of feline hyperesthesia syndrome. Selective serotonin reuptake inhibitors, or SSRIs, like fluoxetine and paroxetine, are common options for anxiety and compulsive disorders in cats. They work by inhibiting the reuptake of serotonin, increasing its availability in the synapses, though the precise mechanism of action remains somewhat unclear. Fluoxetine, in particular, was found in a recent retrospective study to be highly effective, leading to a significantly shorter time to recovery in cats with feline hyperesthesia syndrome compared to other strategies. However, careful monitoring is required when prescribing selective serotonin reuptake inhibitors, as they inhibit liver cytochrome P450 enzymes, necessitating caution when combined with other metabolized medications like phenobarbital. Tricyclic antidepressants, or TCAS, such as clomipramine and amitriptyline, are also used. Clomipramine is often preferred as it is approved for compulsive and anxiety disorders in dogs and cats in some countries and has better anticompulsive action. Amitriptyline blocks the reuptake of serotonin and norepinephrine, acts as an alpha-adrenergic antagonist, and possesses strong antihistaminic properties, making it potentially useful where a pruritic or inflammatory component is present. Emerging therapies, the gut-brain axis. A fascinating and entirely novel therapeutic approach reported recently involves the use of fecal microbiota transplantation. Fecal microbiota transplantation involves transferring fecal material from a healthy donor cat into the affected cat to restore gut microbiota balance. This treatment is hypothesized to work through the gut microbiota-brain axis, a bidirectional communication network between the gut microbiome and the nervous system that influences immunology and neurobehavioral development. Perturbed gut microbiomes have been linked to various behavioral disorders. In a study involving 23 cats with feline hyperesthesia syndrome, fecal microbiota transplantation achieved a high overall clinical response rate of nearly 87%, with most cats achieving clinical remission, and no side effects reported. This approach targets the potential root perturbation in the gut, offering a new avenue for clinical cure, although it remains an investigational new drug treatment requiring specialized knowledge and facilities. Synthesis and prognosis. Feline hyperesthesia syndrome stands as a potent reminder of the intimate connection between the nervous system, emotional health, and physical manifestation of disease in cats. Whether the primary driver is a behavioral disorder exacerbated by environmental stress, a true neuropathic process creating phantom pain, or an underlying focal seizure, successful management relies on identifying and addressing the contributing factors in a comprehensive and adaptive way. The diagnostic workup must be exhaustive, systematically eliminating dermatological and clear neurological diseases before settling on a diagnosis of feline hyperesthesia syndrome. The need to reduce anxiety and stress through strict environmental modification, the 5 pillars, is universal and foundational to all treatment plans, regardless of the drug choice. Prognosis for feline hyperesthesia syndrome is generally considered fair, especially when a systematic and multimodal approach is taken. Many cats, when treated with either pharmacological therapy, behavioral modification, or a combination thereof, achieve a sustained episode-free period of 9 months or more and show an absence of clinical signs at 1-year follow-up. However, relapses can occur, often associated with the discontinuation of medication or exposure to renewed stress factors. This emphasizes that feline hyperesthesia syndrome is a condition that, while controllable, may require long-term or lifelong management, requiring significant commitment from the caregiver. The goal, ultimately, is to elevate the cat's quality of life by reducing the chronic discomfort that stems from this complex maladaptive pain condition. Thank you for listening. The titles for the referenced papers are in the video description. From VetMed Digest, where we keep minds inspired, hearts light, and tails wagging.